Bismillah ar-Rahman ar-Rahim. Dear colleagues, it's my pleasure to introduce the second part of our lectures, left to right shunt, percutaneous and surgical options. In this lecture, we will discuss the VSD, coronary AV fistula, and rupture sinus of Valsalva. We will discuss the anatomy of the interventricular septum. It is composed, from the right side, it is composed of 4 parts. The inlet portion beneath the AV valve till the insertion of the papillary muscle, the trabecular portion, the outlet portion, which is above the subto-marginal trabecula, and centrally located membranous septum, which lies above the crest of the interventricular septum and below the triangle which lies between the non-coronary and coronary cusp. The types of VSD may be below the AV valve at the inlet septum here, or below the pulmonary valve in the outlet septum, which is called subpulmonary or doubly committed VSD, at the trabecular portion, or at the membranous septum. The VSD at the membranous septum may extend to the inferiorly to the inlet septum, which is called perimembranous inlet, or may extend anteriorly to trabecular septum, which is called perimembranous muscular, or may extend upward to the outlet septum, which is called perimembranous outlet septum, VSD. The membranous septum itself is divided by septal leaflet of the tricuspid valve into interventricular portion and the ventriculo-atrial portion. Defects at this portion is called Cherpudi defect. Echocardiography is essential for localization of the VSD. We use different projections. Also, it is essential to determine the effect or hemodynamic impact of VSD in relation to the surrounding structures and presence or absence of pulmonary hypertension. Surgical repair is currently the only option for supracrystal or subpulmonic defects, inlet type VSD, perimembranous defects associated with prolapse of aortic valve and aortic regurg, defects associated with malalignment of the muscular outlet septum, or straddling and overriding AV valves. What are the indications of VSD closure? If there is symptoms of heart failure, failure to thrive, recurrent chest infection, or previous episode of infective endocarditis, or if there is echocardiographic evidence of left ventricular volume overload, or left side volume overload, like left atrium enlargement, or left ventricular enlargement, or if there is QPQS more than 1.5. How can we evaluate the VSD? By transthoracic or transphageal echo. We have to localize the VSD, see the number of VSDs, relation to the surrounding structures like mitral valve, tricuspid valve, moderator band, and especially relation to arterial valve rim. Because if it is absent, maybe we can't close it by transcatheter closure. But if there is 2 millimeter, we can use umbilical duct occluder 1. If there is 3 millimeter, we can use umbilical duct occluder 2. If there is only 1 millimeter, we use the second generation umbilical perimembranous vascular VSD occluder. Also, the weight of the patient. If the patient is 5 kilogram, less than 5 kilogram, we can't close the VSD by arteriovenous loop. He should be more than 5 kilograms, or for muscular VSD closure, or 8 to 10 kilograms for perimembranous VSD closure. According to the guidelines, the only type indicated for transcatheter closure is the muscular VSD. It is considered as class 2A. This is the umbilical muscular VSD occluder. It is composed of 2 It is made of nitinol, self-expandable device, made of 2 discs and the waist in between. It is available in sizes from 4 to 18 millimeter. The waist, the disc, the tension disc is 8 millimeter larger than the waist. This is the procedure of how we close the muscular VSD. We do angiogram to demonstrate the VSD. We calculate the diameter, and then we cross from the left side to the right side, and we snare from the right side, and creating what is known as arteriovenous loop. From the venous side, over this loop, we introduce the sheath. After that, we introduce the left ventricular disc first at the left ventricle, and then do angiogram to be sure that the device in position. Open the right disc and disconnect the device when we are sure that the defect is totally closed and not interfering with any of the nearby structures. Also, we can, in this case, with high muscular VSD, we have to be sure that there is sufficient distance from the aortic valve. In this case, like the previous one, we cross from the left side to the right side, and we snare the wire from the pulmonary artery, creating arteriovenous loop, as we see here. And along this loop, we can introduce the sheath, and then we introduce the device. In this case, we use a bladder duct occluder 1 with 1 disc only, which is used in the BDA closure. But we use it here in the high muscular or perimembranous VSD closure. As you see here, this is the defect, and the device well properly situated with no residual flow. Also, in patient with perimembranous VSD partially closed by aneurysm formation, we can use this device, bladder duct occluder 1, by same technique. We have to be sure it doesn't affect the aortic valve. There are many devices we can use for closure of VSD, muscular VSD, and BFM coil, bladder duct occluder 1, bladder duct occluder 2, or the perimembranous, bladder perimembranous VSD occluder. What are the complications of VSD closure? Suboptimal position of the device. If there is residual shunt, may result into hemolysis, embolization, aortic regurgitation, if the device is very close to the aortic valve, and heart block. The hemolysis, we can appreciate it by the patient come with dark urine and jaundice and anemia. We do the lab workup. Most of cases are treated by conservative treatment and self-limited. If it is persistent, we can close the residual shunt by other device or send the patient for surgery. The problem of heart block became evident after innovation of a specifically designed device for perimembranous VSD, which was asymmetrical to avoid interference with aortic valve, but it caused significant or high incidence of heart block because the distance between the 2 discs was very small. It caused, if you see here, this is arbitrary circle of left disc of bladder perimembranous VSD occluder, and this is the right disc. Here we have the conductive system, the green line, at the infraposterior border of the perimembranous VSD. This device, because the distance between the 2 discs is very small, 1 millimeter or 1.5 millimeter, it causes compression of the conductive system, with high incidence of heart block. While if we use the ambulatory duct occluder one, it has only one disc from the left side, no disc from the right side. It doesn't compress the conductive system. It doesn't cause clamping force or squeezing of this conductive system with lower incidence of heart block. So this device was withdrawn from the market. And the new devices, they consider that the distance between the two discs is wider than this device. The ambulatory duct occluder one consists of flat retention disc and cylindrical body. There is no left atrial disc, right side disc. So it doesn't cause squeezing effect, it doesn't cause heart block, except in rare cases in perimembranous VSD cases. This device is ambulatory duct occluder 2, which is used in BDA closure. It has two retention discs and a central body. It has no fabric inside, so it is low profile device which can be delivered through 4 or 5 French catheters. So we can use it antegrade or retrograde approach. But the maximum diameter of this device is 6 millimeters, so we can't use it in VSDs larger than 6.5 millimeter. This is the technique how we close the perimembranous VSD by ambulatory duct occluder 2. We do angiogram, and then when it introduces the wire and the introducing catheter antegradely, we deploy the right ventricular disc first and withdraw the whole system to the septum. We deploy the left ventricular disc. We ensure that there is no encroachment upon the aortic valve, do angiogram, and disconnect the device. This device doesn't need arteriovenous loop. So many trials about this device in closing perimembranous VSD shows its efficiency and its effect on the conductive system is absent really. It doesn't cause any heart block. We will shift now to other topic, the perforated sinus of Valsalva. It is due to separation of or failed diffusion of the aortic media with the fibrous annulus of the aortic valve. Mainly it is congenital. There are rare acquired causes. The sinus of Valsalva aneurysm, if rupture acutely, it causes acute heart failure and sudden death. Or if it is small and insidious rupture, it causes progressive symptoms of heart failure. Mainly, the site of rupture from the right coronary cusp into the right ventricle, followed by the non-coronary cusp into the right atrium. Other sites are rare sites. Also, we can close these defects by transcatheter approach. As we see here, this is right coronary cusp, rupture into the RV outflow tract. By the same mechanism of VSD closure, we cross and create arteriovenous loop. After that, from the right side, we introduce the sheath and the occluder. Also, we can use ambulatory duct occluder 1. This technique is very efficient, and also it may be life-saving in acute cases. We shift now to the coronary AV fistula. As we know, the extent of the shunt is determined on the fistula size and the pressure gradient between the coronary artery and the drainage area. The fistula may be small and asymptomatic. There is just a murmur, or it may cause volume overload and congestive heart failure, or may cause steal phenomena, which result in angina and chest pain. Rarely it rupture or may cause myocardial infarction or infective endocarditis. What are the indications of coronary AV fistula closure? Heart failure and growth impairment in children because of significant left-right shunt. Clinical feature of large left right shunt, cardiomegaly on X-ray or echocardiography, myocardial steal on stress ECG or myocardial perfusion scan, aneurysmal fistula with risk of rupture or thrombosis, progressive enlargement of fistula on serial follow-up, coronary artery fistula in the setting of single coronary artery. This fistula, this one example, this fistula of LAD that open into the pulmonary artery. It causes significant left-right shunt, cardiomegaly, and also myocardial ischemia. Through a microcatheter, we can introduce detachable coils to close this fistula with perfect outcome. Or sometimes in children we have fistulas like this one, which may open in the right atrium, like this case, causing significant left-right shunt, repeated chest infection, growth retardation, cardiomegaly, heart failure. Also, we can close it. This is the fistula, as you see here, open into the right atrium. Also, we can close it by the same technique of VSD closure, by creating AV lobe, and then close it by the various types of occluders. One of them is ambulazar duct occluder one. So, at the end of this presentation, the elaborated evaluation is needed before decision making in treatment of left-right shunts, small hemodynamically insignificant shunts, as well as large shunts having advanced pulmonary vascular disease should not be closed. Percutaneous intervention in treatment of left-right shunts is safe and effective modality in well-selected cases. Thank you very much.